Bismillah. You need to read these clinical scenarios carefully and answer the questions after these clinical scenarios. So read question number 1. You have 20 seconds to read question number 1. Then question number 2. At the end of our session, we will discuss in detail about the answers of these questions. So read very carefully these questions and answer these questions based on your previous knowledge. Question number 3. Question number 4. Okay, today we will discuss about primary and secondary hyperaldosteronism. Before we start our topic, it's very important to understand the structure of adrenal cortex. As you all know, the adrenal gland, it consists of adrenal cortex, which makes around 80% of the weight of adrenal gland, while 20% of weight of adrenal gland that is made up of medulla. And this is the innermost structure of adrenal gland, that is adrenal medulla. So the cortex is further divided into three zones, that are zona glomerulosa, the outermost zone, the outermost layer, then zona fasciculata, the second layer, and then zona reticularis, the third most layer, the innermost layer of adrenal cortex. So the outer layer is zona glomerulosa, middle layer is zona fasciculata, and the innermost zone is zona reticularis. Okay, and inside the adrenal cortex there is a structure that is known as adrenal medulla. But we are not concerned with adrenal medulla today. We will discuss about the structure that is known as zona glomerulosa, the outermost layer of adrenal cortex, because we are very much concerned about this structure. Zona glomerulosa produces mineralocorticoid, and mineralocorticoid, the most important mineralocorticoid is aldosterone. Zona fasciculata, that is around 78% of the weight of adrenal cortex, that produces glucocorticoids. And then zona reticularis, 7% of weight of adrenal cortex, it synthesizes sex steroids, adrenal sex steroids. So this is very important structure, the JG apparatus, JGA, juxtaglomerular apparatus. Actually, juxtaglomerular apparatus is a point of contact between distal convoluted tubules and efferent arterioles. So look at the structure of efferent arteriole and efferent arteriole here. This is a structure that is efferent arteriole. And in efferent arterioles, there are modified smooth muscles. and these modified smooth muscles, they are named as juxtaglomerular cells. They produces a substance that is known as renin. It controls or regulates your blood pressure via a system that is known as renin aldosterone system. This is efferent arteriole. We are not very much concerned about this structure at the moment. This is another structure, that is distal convoluted tubule. There are some modified cells in the distal convoluted tubules. These are the modified cells in the distal convoluted tubules at the junction with efferent arteriole. This is efferent arteriole and this is distal convoluted tubule. So the junction of efferent arterioles and distal convoluted tubules. This structure, this whole structure is named as juxtaglomerular apparatus. The modified cells in the distal convoluted tubules. These are the modified cells in the distal convoluted tubules. These are known as macula densa cells. These macula densa, this actually detects the osmolarity of fluids in the distal convoluted tubules and regulate your water and electrolyte balance. So this is a very important structure. In the coming 4 or 5 slides, we will discuss about the structure and the pathophysiology of the renin aldosterone system. If you understand the pathophysiology, the structure of juxtaglomerular apparatus and how it produces its effect, you can easily understand the rest of my talk. Very important to understand this slide and the coming 3 or 4 slides. So I think you might be very clear about the juxtaglomerular apparatus. The efferent arteriole, the special cells in the efferent arterioles at the junction of distal convoluted tubules. These cells, these are known as juxtaglomerular cells. These cells produce renin that controls your blood pressure. And this is distal convoluted tubules, the specialized cells at the junction of efferent arterioles and this distal convoluted tubules. These cells are known as these cells are known as macula densa. Macula densa. It detects the osmolarity in the distal convoluted tubules. So whole this apparatus, I will repeat the whole this apparatus, this is known as juxtaglomerular apparatus. So again, the elaboration of the previous slide, this is efferent arteriole. You all know the structure of a nephron, the efferent arteriole. And this structure, what is the name of this structure? Efferent arteriole will lead towards glomerulus. This structure is glomeruli, and after glomeruli, blood leaves this structure, enters from efferent arteriole or filters from efferent arterioles into glomerulus and subsequently into the Bowman capsule, and this blood is returned in the efferent arteriole in the circulation. Okay, so this is the structure of a nephron. This is a capsule. This is known as a cup-shaped structure. This is known as Bowman capsule. So the blood coming from efferent arterioles into glomeruli, some of the blood is filtered into the Bowman capsule and obviously will go towards proximal convoluted tubules, and the rest of blood from efferent arteriole into glomeruli will go towards efferent arteriole and subsequently in the blood. So this is a structure. We will discuss the very important structure, juxtaglomerular apparatus. This is a distal convoluted tubule. These are the specialized cells in the distal convoluted tubules. That these cells are known as macula densa cells. These cells are the mesangial cells, the supporting cells, and there are specialized cells, smooth muscle cells in the efferent arterioles, juxtaglomerular cells. These cells produce renin, substance known as renin. So this structure is, I think, very much clear, the juxtaglomerular apparatus. So the juxtaglomerular apparatus, it synthesizes and stores renin, and this renin is released into the blood, and it is hydrolyzed by this renin is hydrolyzed into angiotensinogen and subsequently hydrolyzed to angiotensin 1 in the circulation. So renin that will be released into the circulation will hydrolyze angiotensinogen into angiotensin 1, and there is an other enzyme that is known as angiotensin converting enzyme ACE that is present in lung. This angiotensin converting enzyme converts angiotensin 1 into angiotensin 2, and the subsequent effects of these things, these are the mediated through angiotensin 2. Angiotensin 2 causes vasoconstriction of the blood vessels, number 1. Number 2, it stimulates the zona glomerulosa cells to produce aldosterone. So angiotensin 2 produces two effects. One is vasoconstriction of the blood vessels, and number 2 effect is it stimulates the zona glomerulosa cells in the adrenal cortex to produce a substance that is known as aldosterone. So again, renin produced from juxtaglomerular apparatus in the kidney, in the nephrons, it converts a substance that is released from the liver that is known as angiotensinogen. It converts angiotensinogen into another substance that is known as angiotensin 1, and this angiotensin 1 is converted by an enzyme that is known as ACE enzyme, angiotensin converting enzyme in the lung. It converts angiotensinogen 1 into angiotensin 2, and angiotensin 2, it stimulates the zona glomerulosa in the adrenal cortex. Zona glomerulosa, it stimulates to produce aldosterone, and aldosterone goes into blood and it causes sodium and water retention in the collecting duct in the kidneys. It causes salt and water retention, leads to increased blood volume and subsequently increase in blood pressure. The other effect, this is sodium absorption into the circulation along with water absorption. This is mediated by aldosterone in the distal convoluted tubules. The other action of aldosterone is it causes potassium, waste of potassium, loss of potassium into the urine. So it leads to hypokalemia. So it causes, if we summarize what causes aldosterone, it causes sodium and water retention into the circulation, and it causes loss of potassium into the urine. So hypokalemia is one of the effects of aldosterone, while sodium and water retention, the other effect. So whenever there is drop in blood pressure or there is hyperperfusion of kidneys, it causes the release of renin from kidneys, from the juxtaglomerular apparatus of the kidney, and this renin converts angiotensinogen produced from liver into angiotensin 1, and this angiotensin 1 is converted into another substance that is known as angiotensin 2 by an enzyme known as angiotensin converting enzyme that is released from the lung. And this angiotensin 2 produces two effects, as I have already discussed. It causes vasoconstriction, so leads to increased blood pressure, tries to increase the blood pressure. On the other hand, it causes adrenal gland to stimulate the release of aldosterone, and this aldosterone acts on the kidney to stimulate the reabsorption of salt and water. So on one side there is vasoconstriction, on the other hand there is absorption of salt and water. So the first effect is drop in blood pressure and drop in blood volume, and this substance, this whole mechanism, it produces increase in blood pressure through vasoconstriction and increase blood volume through increase through stimulation of absorption of sodium chloride and water in the collecting ducts in the kidneys. So it restores the circulation, so it restores the blood pressure. Again, what we summarize the effect of aldosteronism, hyperaldosteronism. It causes hypertension because it leads to sodium reabsorption and subsequently absorption of water. So there is absorption of sodium chloride and water leads to increased plasma volume, leads to hypertension. The other effect, this is hypertension, one of the effect of hyperaldosteronism. The other effect is excretion of potassium into the urine that causes hypokalemia. So hypokalemia clinically manifests as muscle weakness, metabolic alkalosis, and polyuria, because hypokalemia is one of the cause of nephrogenic diabetes insipidus. Okay, so hypokalemia and hypertension, these are the two main effects of aldosteronism, the hyperaldosteronism. So what is primary hyperaldosteronism? Anything that causes increased release of aldosterone from the zona glomerulosa of adrenal cortex will lead to primary hyperaldosteronism. So obviously when there is increased excretion of aldosterone, excess of aldosterone in the zona glomerulosa of adrenal cortex, it will inhibit the release of renin in the juxtaglomerular cells in the kidney because of negative feedback. So there is increased aldosterone, while on the other hand there is low renin. So what are the causes of primary hyperaldosteronism? Obviously we know in primary hyperaldosteronism the pathology is there in adrenal cortex. The pathology might be adrenal adenoma in 20 to 30% of the cases, while in most of the cases, in 60 to 70% of the cases, it is because of idiopathic bilateral adrenal hyperplasia. And there are two other causes of primary hyperaldosteronism. These are adrenal carcinoma and glucocorticoid remediable hypertension. But glucocorticoid remediable hypertension is beyond your scope. We will not discuss with you people. So in primary hyperaldosteronism, I think you should be crystal clear that pathology is there in adrenal cortex. So there will be increased aldosterone level, while there will be decreased renin level because of negative feedback. So what happens in secondary hyperaldosteronism? In secondary hyperaldosteronism, the pathology is not there in adrenal cortex. Pathology is there somewhere else. The most common cause of secondary hyperaldosteronism is impaired renal perfusion. Anything that impairs renal perfusion or anything that reduces the effective circulatory volume will lead to increased renin excretion from the juxtaglomerular cells in the kidneys, as we have already discussed, that will ultimately lead to increased aldosterone excretion. So in secondary hyperaldosteronism, there will be high renin and high aldosterone level, while in primary hyperaldosteronism, the aldosterone levels were high while renin levels were low because of negative feedback. So what are the causes of renin of the hyperperfusion of the kidney that are because of reduction of effective circulatory volume? These are cardiac failure, liver failure, nephrotic syndrome, diuretic therapy, renal artery stenosis. All these conditions will lead to impaired or hyperperfusion of the kidney or they produces a reduction in effective circulatory volume. So ultimately leads to increased renin and obviously leads to increased aldosterone excretion. There is another condition that leads to secondary hyperaldosteronism. That rare condition is known as renin secreting tumor. That the pathology is there in juxtaglomerular cells. There is reninoma. There is increased excretion from this renin secreting tumor that will subsequently stimulate the adrenal cortex to produce aldosterone. So both renin and aldosterone will be high in this condition. So now we will discuss about primary hyperaldosteronism. It is responsible for 5 to 13% of cases of hypertension. It makes up around 0.6% of the adrenal incidentomas. What are adrenal incidentomas? As we all know, because of increased imaging modalities in the modern days, there is increased chance that we detect adrenal lesions. So these adrenal lesions that we detect by chance on imaging of adrenal, on the imaging of abdomen, um, that that lesion we label those lesion as adrenal incidentoma. And when we come across any adrenal incidentoma, in any adrenal incidentoma, we have to screen uh, those patients for primary hyperaldosteronism, whether hypertension is there or not. In 1964, a scientist known as Pons, he described this condition, primary hyperaldosteronism, in hypertensive population, and he suspected that it could be uh, the one of the most important secondary cause of hypertension, the cause of secondary hypertension. Around it, he described at the time that the primary hyperaldosteronism might be the cause of hypertension in around 20% of the cases. But subsequent studies revealed that primary aldosteronism prevalence is 3% in hypertensive people, 39% in resistant hypertension, while 6 to 10% of hypertensive patients referred for difficult to manage hypertension or when there is suspicion for primary aldosteronism. So what is resistant hypertension? Hypertension that is poorly controlled on optimal doses of at least 3 antihypertensive drugs, including a diuretic. That is known as resistant hypertension. So again, you need to understand what is resistant hypertension. Any hypertension that is poorly controlled on optimal doses of 3 antihypertensives, including a diuretic, that is known as resistant hypertension. So this is the prevalence of primary hyperaldosteronism in hypertensive patients in different populations. In India, its prevalence is around 8.7% in hypertensive population, while in United States it is around 12%. In United Kingdom it is around 9.2%. So quite a high prevalence of primary hyperaldosteronism in hypertensive patients. So the most important cause of secondary hypertension in hypertensive population is primary hyperaldosteronism. So this is the criteria for screening for primary hyperaldosteronism in patients. So these patients should be screened for primary hyperaldosteronism. Number 1, young onset hypertension. Number 2, hypertension with hypokalemia. Even patients are on diuretics. Hypertension with hypokalemia, very important. Very important finding to screen that patient for primary hyperaldosteronism. Number 3, resistant hypertension. Number 4, adrenal incidentoma. Number 5, strong family history of early onset of hypertension or hemorrhagic strokes at younger age. So in all these patients, you have to screen for primary hyperaldosteronism. So what are the signs and symptoms of primary hyperaldosteronism? In most of the patients, it is asymptomatic. You won't come across any symptoms in these kind of patients. Hypertension. Hypertension is there in patients with primary hyperaldosteronism, in most of the patients with primary hyperaldosteronism. But it is but malignant hypertension is rarely seen in these kind of patients. Hypokalemia is present in 40% of the cases that leads to muscle weakness and polyuria. We have discussed that there is retention of the sodium, chloride and water in hyperaldosteronism, but there is a lack of edema in these kind of patients because long-standing hyperaldosteronism leads to high aldosterone escape, because there is increased diuresis, increased urinary volume that leads to aldosterone escape, and so there is no edema clinically seen in these kind of patients. There is metabolic alkalosis. Obviously, when there is hypokalemia, there is metabolic alkalosis. That metabolic alkalosis might lead to tetany because of decreased binding ability of the calcium to protein. So these are the biochemical investigations that should be carried out in every patient with primary hyperaldosteronism. These are serum potassium, obviously hypokalemia, present in 40% of the cases with primary hyperaldosteronism. Then serum aldosterone level, obviously it is elevated, markedly elevated in patients with primary aldosteronism, while plasma renal activity is suppressed because of negative feedback in these kind of patients. The most important test in these kind of patients, this is aldosterone renin ratio. This is the screening test, the most important. The initial screening test in any patient with primary hyperaldosteronism is ARR ratio, aldosterone renin ratio. So if you come across any MCQ in your life, what is the best screening test, or what is the initial screening test for hyperaldosteronism? The best screening test is always ARR ratio. So we can localize the lesion on CT scan of the abdomen or MRI. So very difficult to localize the adrenal gland in normal patient, as shown by these red arrows. Very difficult to localize the normal adrenal. But when there is some lesion, some mass in the adrenal, you can easily localize. You can localize because it's a huge lesion, 4.8 into 4.6 centimeter on the right adrenal gland. This is a huge lesion detected on CT scan of the abdomen in patient with primary hyperaldosteronism. This is the unenhanced CT scan. Obviously, lesion is large. We can see even on unenhanced CT scan, but when the lesion is small, we can miss this lesion on unenhanced CT scan. But after contrast enhancement of this CT, we can very well localize the lesion. You can very well localize this kind of lesion. So this lesion was very much visible even on an enhanced CT scan, but small lesions, they are missed in unenhanced CT scan. That those small lesions, they can be picked with contrast enhanced CT scans. Okay, this is the adrenal. This is a tumor, adrenal adenoma, in patient with primary hyperaldosteronism. So the ARR ratio, there are certain prerequisites for measurement of aldosterone renin ratio, because if you won't follow these prerequisites or these kind of measures, you can falsely over or under detect the hyperaldosteronism on this screening, and you can miss many cases. So what are the prerequisites for aldosterone-renin ratio measurement? Number one, it should be checked in mid-morning when the patient is up for 2 hours, sitting and standing and cannulated for 15 minutes. Number two, sodium diet needs no restriction before ARR testing. Number three, normalize potassium with exogenous potassium containing preparations. Number four, stop diuretics at least 4 weeks before testing. Number five, stop ACE inhibitors, ARBs, beta blockers, centrally acting alpha agonists 2 weeks before the test. So when you detect that a patient is having primary hyperaldosteronism based on high aldosterone level and suppressed plasma renin activity or aldosterone renin ratio, you need to go for confirmatory tests. But these confirmatory tests are beyond your scope. You obviously straight away move towards adrenal CT scan, the best imaging modality for to detect these kind of lesions. In adrenal CT scan, if you find a unilateral nodule, and if the age of the patient is less than 40 years, very important slide, very important. If the age is less than 40 years and the size of tumor is more than 1 centimeter and enhancement on CT scan is less than 10 Hounsfield unit. Three criteria: less age less than 40, unilateral nodule, age less than 40 years, nodule more than 1 centimeter, and nodule with less than 10 Hounsfield intensity on pre-contrast CT scan of abdomen. If you find all these things, you need not to lateralize the lesion by a technique that is known as adrenal venous sampling. You straight away go for surgery. But if the size of nodule is less than 1 centimeter, whatever the age of patient may be, or the adrenal looks normal, or there are multinodular lesion or unilateral or bilateral enlargement of the adrenal gland, you go for a test that is known as adrenal venous sampling, in which you cannulate the adrenal veins bilaterally through a catheter from femoral vein. You approach right and left adrenal veins, and you measure the aldosterone levels, and you localize where is the aldosterone excess, either on left side or right side, based on this testing. So once you have localized the lesion based on adrenal venous sampling, either on left or right side, you go for laparoscopic adrenalectomy or surgery of that particular site. But if after adrenal venous sampling you won't be able to localize the lesion, you need to rely on medical treatment option. The medical treatment option is mineralocorticoid receptor antagonists. So adrenal venous sampling is not required if the patient is not suitable candidate for surgery, or patient doesn't have any wish to undergo surgery. So it is only required when you plan surgery. When you don't plan surgery, don't go for adrenal venous sampling. If you plan surgery, go for adrenal venous sampling. Lateralize lesion. If lateralize, go for surgery. If you weren't able to lateralize, go for medical treatment option. But if the patient is a poor surgical candidate, you have to rely on medical treatment option, mineralocorticoid receptor antagonist. So again, this is the repetition of the previous slide. Again, when you detect a case, you go for confirmatory tests. You go for adrenal CT scan, and if surgery is, and if you localize the lesion, or if the size of tumor is more than 1 centimeter, age of patient is more than 40 years, there is hypokalemia, and there is less than 10 Hounsfield unit intensity on pre-contrast CT, you need not to go for adrenal venous sampling. In all other cases, when you plan surgery, you need to go for adrenal venous sampling to localize surgery, and subsequently go for laparoscopic adrenalectomy. In all other cases, if you weren't able to localize the lesion, or if the patient is a poor surgical candidate, you will go with medical treatment option. So treatment, we have already discussed the surgical treatment option or medical treatment option. Surgical treatment option is obviously the laparoscopic adrenalectomy. It is curative. While in medical treatment options, mineralocorticoid receptor antagonists, they are used like spironolactone, the treatment of choice. In medical treatment options, spironolactone, if the patient is resistant, intolerant, or having some side effects with spironolactone, you may go for the other drug, that is eplerenone. So these are the outcome of surgery after laparoscopic adrenalectomy. Hypertension is cured in 40 to 60% of the cases and improved in all cases. Hypokalemia and hyperaldosteronism are cured in almost all cases undergoing surgery. Question number 1. A 35 years old man presented with uh, feature of high blood pressure, strong family history of blood pressure, hemorrhagic stroke, and he's having hypokalemia. So hypertension with hyperkalemia with family history of hypertension with hemorrhagic strokes. What is the most probable diagnosis? So it's a very obvious that diagnosis is primary hyperaldosteronism. So what will be the best initial screening test for primary hyperaldosteronism? As I have clearly mentioned in my talk, that the best initial screening test for primary hyperaldosteronism is always and always ARR ratio, aldosterone renin ratio. Question number 2. 30 years old man with all the features of primary hyperaldosteronism clinically as well as biochemically. Suppressed plasma renin activity, very high plasma serum aldosterone levels, and CT abdomen showing a left adrenal mass which is more than 1 centimeter. So look at the age of patient, 30 years, typical features of hyperaldosteronism with hypokalemia, and CT showing mass of more than 1 centimeter in the left adrenal gland. Which one of the following will be the most appropriate next step in his further management? So obviously patient is less than 40 years of age, CT showing mass more than 1 centimeter with hypokalemia, typical primary hyperaldosteronism. So what will be the best treatment option in this patient? Surgery. Option C, laparoscopic left adrenalectomy. Again, the repetition of the previous clinical scenario, but see the age of the patient. Now the age is 55 years. All of the parameters, clinical as well as biochemical parameters, are the same. So age is more than 55 years, and patient is having all the clinical and biochemical evidence of hyperaldosteronism. CT containing mass of more than 1 centimeter, but age is the limiting factor. So which one of the following is the most appropriate next step in his further management? So the most appropriate next step after 40 years of age in patients with primary hyperaldosteronism, if even you detect a mass on CT abdomen, the most appropriate next step in these kind of patients is option A, adrenal venous sampling to localize the lesion, because the incidence of solitary adrenal adenoma, that is also known as adrenal incidentaloma, on routine imaging of abdomen, this is a common entity. So in these kind of patients, you have to go for laparoscopic you have to go for adrenal venous sampling, option A, to localize the lesion, whether the lesion is on right side or left side. So question number 4. For 50 years old man having all the features of primary hyperaldosteronism, CT abdomen showing 1.3 centimeter left adrenal mass, and there was no lateralization on adrenal venous sampling, which one of the following will be the best treatment option? Primary hyperaldosteronism, no lateralization on adrenal venous sampling, so we have to rely on medical treatment option, in these kind of patients. So obviously the best medical treatment option in these kind of patients would be spironolactone. So I will go with option D, spironolactone. So this is all about my today's talk. Thank you for your active listening. Allah Hafiz.